All right, let's get right into it. The official rule book that doctors use for treating heart attacks, it just got a massive rewrite, the first one in years. We're talking about the brand new 2025 guidelines from the American College of Cardiology and the American Heart Association. And believe me, they are packed with some serious practice-changing updates. You know, when someone's having a heart attack, it is literally a race against time. Every single second matters. It's that critical moment where doctors need a playbook to make split-second, life-saving calls. So when that playbook changes, it is a very big deal. Let's break down what's new. First up, just a quick definition so we're all on the same page. You're going to hear the term acute coronary syndrome, or just ACS. Think of it as the umbrella term doctors use for any situation where the heart's blood supply is suddenly cut off, from bad chest pain all the way to a full-blown heart attack. At the end of the day, it's all about a sudden blockage. So to get our heads around all this, we're going to break it down into the 4 biggest, most important updates. We're talking about how doctors fix blocked arteries, how they stop new clots from forming, how low they're pushing cholesterol, and a pretty shocking reversal in how they support a failing heart. Okay, let's kick things off with the first major shift. This one is all about the strategy for clearing out those blocked arteries. It's a move away from just fixing the one problem artery to what they're calling a more complete approach. So here's the key difference. Before, with the most serious kind of heart attack, a STEMI, the standard was to open up the main culprit artery and then maybe, just maybe, bring the patient back later to deal with any other blockages. Well, not anymore. The 2025 guidelines now say fixing all the significant blockages is a top-level Class 1 recommendation, and that's the strongest stamp of approval a treatment can get. It means the evidence is absolutely rock solid. And that begs the question, right? Why the big change? What new information drove such a fundamental shift in strategy? Well, like always in medicine, the answer is in the data. The reason is that the evidence just became overwhelming. A couple of landmark trials, PREMI and then COMPLETE, both showed that when doctors went in and fixed all the significant blockages, what they call complete revascularization, it dramatically cut the patient's risk of dying or having another heart attack down the road. The evidence was just too powerful to ignore. The new guidelines even get specific about the timing. Before, fixing everything in one procedure was kind of a weak thought, an afterthought really. But now, thanks to newer trials, for the right patient, someone who's stable and whose blockages aren't too complex, the guidelines actually prefer getting it all done in one go. It just makes sense. One procedure, one recovery. All right, let's move on to our second pillar. After a doctor puts in a stent to open up an artery, you absolutely have to prevent new clots from forming on it. That's done with something called dual antiplatelet therapy, or DAPT. And the whole strategy here has been revolutionized. Now, this is a really big deal. For years, the standard was at least 12 months on 2 of these anti-clotting drugs. The problem? That comes with a real risk of bleeding. So now, a new strategy called de-escalation has a top-level recommendation. For a lot of patients, after just 1 month, they'll stop the aspirin and just continue with the stronger drug, ticagrelor. This is all about finding that perfect balance, reducing bleeding risk without raising the risk of another clot. And this table really lays out the new, more personalized game plan. You can see for standard risk patients, there's that option to go with ticagrelor alone after a month. But look at patients with a high bleeding risk. The timeline gets even shorter. And for people who need other blood thinners, the guidelines are crystal clear. Get them off that risky triple therapy of 3 drugs within weeks, not months. It's all about tailoring the treatment to each individual. Our third pillar is all about getting way more aggressive on cholesterol. After a heart attack, the new mantra is simple: lower is better. And we've got new targets and new tools to make that happen. I want you to remember one number, 70. This is the new line in the sand. The guidelines now give a Class 1 must-do recommendation that if a patient is on the strongest statin dose possible and their bad LDL cholesterol is still at or above 70, you have to add another non-statin drug. There's no more wait and see. And the push to go lower doesn't even stop there. For the very first time, even if a patient's LDL is already pretty low, down in that 55 to 69 range, the guidelines say it's reasonable to add another drug to push it even lower. They're also stronger than ever on using other drugs if someone can't tolerate statins, and they even float the idea of starting 2 drugs right from day 1. The message here is unmistakable: be aggressive and be early. Okay, our final pillar is maybe the most dramatic one of all. It deals with a terrifying complication called cardiogenic shock.
That's when the heart is so badly damaged from the attack, it just can't pump enough blood to keep the body going. And in this area, the guidelines have made a truly shocking reversal of a practice that's been around for decades.
For more than 40 years, when a heart was failing like this, doctors would often use a device called an intra-aortic balloon pump, or IABP. The old guidelines said this was reasonable, but the 2025 guidelines, a complete 180. It is now explicitly not recommended. Why? Because a huge definitive trial finally proved that despite being used for decades, it simply doesn't save lives. So, if the old tool is out, what's in? Well, take a look at this chart. This is data for a newer, much more powerful heart pump called the Impella device. The results from a trial called Danger Shock are just, wow. Look at that difference. There is a huge drop in the death rate for patients who got the Impella device. That is a massive survival benefit. And so for the very first time, the guidelines make a specific recommendation for these powerful little devices. They're basically tiny pumps that get threaded up into the heart to help it do its job. It says that for the right patient, using one is reasonable to reduce the risk of dying.
But that leads to a really important question, doesn't it? If this device so clearly saves lives, why is the recommendation only a reasonable Class 2B and not a stronger, you should do this, Class 1 recommendation? And this is where medicine gets really tough. It's all about trade-offs. The very same trial that showed the survival benefit also showed that the Impella device comes with a much higher risk of really serious complications, things like severe bleeding or damage to the artery in the leg. So while it can be a lifesaver, it has major risks, and that's why the recommendation is cautious and really stresses that you have to pick the right patient.
So after covering these 4 huge updates, let's just step back. What's the big picture? What does this new 2025 heart attack rulebook really mean for patients? Well, when you zoom out, 4 clear trends really pop out. Care is becoming more comprehensive, fixing the whole problem, not just one piece of it. It's becoming more personalized, especially with those anti-clotting drugs. It is way more aggressive when it comes to cholesterol. And maybe most importantly, it's more evidence-based than ever, showing that doctors are willing to throw out old habits when the new science is clear. You know, these guidelines are a snapshot of the absolute best science we have right now. They're a huge step forward, but they're also a reminder that medicine never stands still. And that kind of leaves you with a final thought, doesn't it? What's the next big discovery? What's the trial that's happening right now that will force us to rewrite this rulebook all over again?